So because we need a million categories for a million different things, we can further separate our leukemias into acute and chronic, and these are determined based on clinical symptoms, the maturity of the cells that are affected, and then the total leukocyte count. So for acute leukemias, this is going to be a short, sudden condition, and it happens abruptly, and it can kill in a short amount of time. So it can kill quickly. Usually you'll see a lot of immatures in both the bone marrow and in the peripheral blood, and if it's not treated, the white blood cell count will just continue to increase. And then we have our chronic leukemias, and this can smolder for years. This is where you're going to see mostly mature white blood cells in bone marrow and peripheral blood. And the WBC count can range anywhere from low to super high. And we'll talk about why that is later on, but just really quickly, chronic leukemia can, develop into an acute leukemia, or it can develop into myelodysplastic syndrome. A little bit more detail on the acute leukemias. Again, this is an abrupt onset. Life expectancy is going to be anywhere from weeks to months, and that is if it is left untreated. It is found more often in children than it is in the elderly, but it can affect anybody of any range or any age range. It's more common than the chronic leukemias, and in the bone marrow and peripheral blood, you're going to see those immature cells. So your myeloblasts, your promyelocytes, and or your lymphoblasts, obviously depending on the type of leukemia the patient has. An interesting thing about acute leukemia is it can occur within the bone marrow and then all of a sudden spill out into peripheral blood. And then once it spills out, then we're going to see that high white count in peripheral blood. So when we say it can be variable here as far as the white blood cell count, some patients will go in with like maybe some bone pain or some other random symptoms, and they'll have a decreased white blood cell count at roughly 2,000 per microliter. And at that point, they might not have had that spill into peripheral blood yet. Okay, so what are we going to see in the lab? We're going to have normochromic normocytic severe anemia, also thrombocytopenia. And the reason for this is that there's no room in the bone marrow for normal cells of other cell lines. Okay, we're going to see some lymphadenopathy, some enlarged liver and spleen. And then the leukemic cells can appear in spinal fluid. It does depend on the type of leukemia, but when they spill over, it's not just necessarily in peripheral blood. Now these two, we're talking about treatment. So treatment is going to cause that low white blood cell count. And then immunosuppression. This is going to be with or without treatment. So without treatment, immunosuppression is occurring because the white blood cells are not functioning properly. So they're not able to fight off foreign bodies. And then with treatment, the white blood cells are being killed off. So there's just not enough white blood cells to do any fighting. For the most part, symptoms of acute leukemia are pretty nonspecific. Weakness, pallor, bleeding because of those low platelets, bruising, same thing, fever, vomiting, which I think is spelled wrong, headache, bone or joint pain. That's kind of even though it's not specific, it's more pointing towards something going on within the bone marrow. And then recurrent infections, which indicates something is wrong with the WBCs. And I do just want to add to this bone marrow and joint pain. This also has to do, specifically the bone pain part, with the expansion of the bone marrow. So the bone marrow can actually expand to accommodate all of those white blood cells that are being made, but it's painful and it can only expand so far. It used to be that a diagnosis of acute leukemia was a death sentence, because untreated, obviously before there was any treatment, patients would only live weeks to months. Okay, still today, if they go untreated, weeks to months is the survival, and then it's ultimately going to be fatal. Radiation therapy, which was invented in the 1920s, that was huge in the leukemia world because it did increase life expectancy. Okay, we still use it today. And the way it works is that it damages the DNA of the cells, resulting in cell death. And this is cell death of both the bad leukemic cells and the good healthy cells. In the 1940s, drug therapies first started to come into play. Chemotherapy is a big one, still use it today. And the way a lot of these drugs worked is it would interfere with, I don't know how to spell, with the cell's life cycle. That's cycle, C-Y-C-L-E. So then we would see a decrease in the number of cells within the bone marrow, which is good, but again, it would kill both good and bad cells. Okay. The toxicity has gotten better over time. It used to be that chemotherapy was very toxic. Nowadays, it's still toxic, but less toxic. And there are also drugs now that will attack at the molecular level, so they're called targeted therapy. Gleevec is a big one, and this one came about in my lifetime, so it's been around for a really long time. But it affects or targets the Philadelphia chromosome, which is a 922 chromosome, and we'll talk more about that later. But this drug is used to treat acute lymphoblastic leukemias as well as chronic myelogenous leukemia. And then there's rituximab, used to treat ALL, acute lymphoblastic leukemias. Bone marrow or stem cell transplant is also an option for certain people. There are risks associated with it. There's risks associated with all treatments. But you might also hear bone marrow transplants, stem cell transplants, called hematologic progenitor cell transplants, or HPC. So then moving on to chronic forms of leukemia. Again, this is slow and subtle. Some people don't know that they have it for many, many years. Life expectancy can be anywhere from months to years. And when we talk about life expectancy, we're talking about at the time of diagnosis, because we can never pinpoint when someone starts developing a leukemia. Okay. This form, the chronic form, does mostly occur in adults, and then the incidence or the risk of it does increase with age. In the bone marrow, it's going to be mostly mature differentiated cells. Same with peripheral blood, bone marrow and peripheral blood. Some matures may be present depending on the stage of the chronic leukemia. Then patients will have prominent hepatosplenomegaly, and then the white blood cell count is going to be high because the number of cells in the bone marrow is going to be high, and those kind of spill out over time. In the lab, we're going to see normochromic normocytic anemia. This will worsen as the disease progresses. Our platelet count will be anywhere from normal to increased. but then it will decrease. Oh, I wrote that down here. It will decrease as the disease progresses. And then this may develop into a blast crisis or an acute leukemia. And our peripheral blood then will reflect that of acute leukemia. I feel like maybe I just ran over this too quickly, but blast crisis, I want you to remember that term. A chronic leukemia can end up in a blast crisis in which the patient would have an acute leukemia. Doctors probably won't change their diagnosis from chronic to acute because once a chronic converts to an acute, things don't always end well. Symptoms of chronic leukemia, insidious onset, that just means gradual. And usually chronic leukemias are found by mistake or by accident during a routine physical exam. So that's why the life expectancy varies from weeks to years, because it just kind of depends on when it becomes discovered. Sorry, I meant months to years. Prognosis and treatment for chronic leukemia. Again, if it's left untreated, that's when your life expectancy is going to be months to years. And then continue to be untreated, it's essentially going to be fatal. Radiation therapy, very similar or the same as for acute leukemias. Works the same way. It's the same thing. And then all of this is the same as with acute leukemias as well. So drugs that affect or interrupt the growth cycle of the cell, we're going to end up seeing a decrease in the number of cells in the bone marrow, both good and bad cells. Less toxic. I'm pretty sure I just copied and pasted. Gleevec, and then bone marrow or stem cell transplants. So same treatment, slightly different drug options here and there for chronic leukemias versus acute leukemias. Here's just a couple of picture examples of acute versus chronic lymphocytic leukemia. And this first one, this is the acute. So we have a lot of lymphoblasts that you'll see here. They look like big lymphocytes, but you should be able to see, like in this one, you can see the nucleoli pretty well. And remember, the difference between a blast and a large lymphocyte would be the amount of cytoplasm, plus you're going to look at the what the chromatin pattern looks like. Okay, these blasts are like nice and fluffy looking, pretty homogeneous all over the whole entire nucleus. Whereas on this side, this is chronic lymphocytic leukemia. So this is ALL, and this is CLL over here. So here we still have a lot of lymphocytes, but now they're bigger. And like this one especially is pretty key or characteristic, I want to say, of a large lymph. It has more cytoplasm. We have a little lymph right here. We get a different color. So I want you to take a look at the chromatin pattern here. It's starting to look a little bit stretched. You could almost say, is it starting to maybe turn into a reactive? I wouldn't call it a reactive, but it has that stretched look to it, to the chromatin pattern. But for the most part with CLL, you're going to see these nice little lymphs. This one looks like a little butt cheek. It's got a little crack right there. And now I'm going to have to erase it because you're not going to be able to unsee that now. Anyway, so that's just the difference between acutes and chronics. Acute, you're going to see the immatures. Chronics, you're going to see the majority of them as matures. And then here's an example of acute versus chronic myelogenous leukemia. There we go. Okay. This is a cell vision picture. So this is AML. And we have all of these giant myelocytic blasts. Okay, they look very similar to the lymphocytic blast that we just looked like. So that we just looked at. So when you see a blast, you're not going to say this is a lymphoblast or a myeloblast. You're just going to say that you see a blast, and then that patient's sample is going to go off to the pathologist for that cytogenetic testing and those CD markers. Okay, and then on this side we have CML, and you can see that we have, for the most part, a lot of mature neutrophils. This one is probably a meta, you could argue a meta It's pretty big. It has that little indentation. There's some bands, but for the most part, there's a lot of matures.